morning, Professor. We have a very good luck that you are here for the first time in Poland, and we appreciate this, that you have be here to share your excellent, wonderful knowledge and experience with the area of the pain, sleep, and what is probably the most important for Polish dentists with the bruksizm. So my first question is what is the role of the dentist, or maybe in dentistry, in the aspect of the sleep bruksizm or pain and sleep?
Okay, the role of dentists is to identify problem, to screen for sleep disorders such as insomnia, sleep breathing disorders such as sleep apnea that can be associated with snoring. And doing screening means they can use questionnaire, device to record what's going on, but they need to collaborate with physician to have diagnosis of this condition. Having said this, the role of dentists in sleep medicine is to recognize, diagnose, and manage sleep bruxism.
So we can now say that there's some kind of new discipline, or maybe new bridge or new gap between medicine and dentistry, which is sleep dentistry. Am I correct?
It's like in pain, like in headaches. Dentists and physicians have to work together for the best of the patient, and dental sleep medicine is one of the gaps to fill, and it's why we use dental sleep medicine, because it's not a technique. You need a knowledge of what's going on. It's not a new field. It's an old field that is now working together. It's close to 25 years now in North America where we started to work together as dentists and physicians. So other countries now, for different reasons, are starting doing this kind of collaboration, and I can see it's the same here.
We see that there's a still increasing the interest with the sleep problems or with the airway problems. Hopefully it is probably caused by two reasons. One is the obesity, which overweight patients, which we still have more in our private practice, or we will see them in a clinical routine practice. And the second is that we have an older society. I mean, much more older people, which are also coming to our offices. So in these circumstances, what do you think is the best approach the dentist can collaborate with the physician? Because we know that there's two different groups. One is the children, the second is older patients. So what is the strategy? Maybe it's different or it's the same, because there's a different age group of people.
If we talk for sleep apnea, cessation of breathing during sleep with desaturation, so loss of oxygen to the brain, there is different approach that can be taken. You want to know if dentists can act directly in it or if they need to collaborate. I think, as I mentioned before, we need to collaborate. I'm not exactly sure where you want to take me with your question.
My question is that starting to see the patient, which is a child, what will be the strategy for the child,
for the dentist
with the child, and then when the child is growing up, what will be the next strategy? Because probably because of the age and maturity, there will be completely different approach.
As soon as I see a child who's have problem of attention, hyperactive, problem of headache, school problem, I think at breathing problem, breathing issues. In these children, we have to be sure they have no big tonsil to reduce risk of infection. And in these children, myofunctional therapy is emerging as a strategy to prevent long-term problems. Some children, however, have retroagnosia, deep palate, big tongue, so they need orthodontic treatment. So in preventing long-term consequence in children is an avenue to go. If children grind their teeth, we have also to be sure that they have no breathing issues, they have no allergies, And children sometimes grind due to brain development. We don't know exactly what's going on. The children who grind, about half of them will not grind when they will be adult. Some will continue to grind for their life, but with age, bruxism is going down.
And what about the adults?
Adult,
Teenagers and adults?
Yeah, teenagers, difficult to say because teenagers have a different sleep schedule. They tend to clench, have more clenching than grinding because their sleep is different. They sleep at different times. It's difficult to isolate them. For sleep apnea, when teenagers have headaches, attention problem, then we need to go with oral appliance, rarely CPAP. They are too young. And again, we need to look at nose obstruction, tonsil. We need to do a complete exam. And as dentists, we can identify risk for this, but we need to collaborate with otorhinolaryngologists. We need to collaborate with family physician and with respiratory physician. For bruxism and apnea, it's about the same thing we have to search. When you get in adult, body mass index, overweight is something to correct. Exercise, again, can help, not as much as in children, to increase muscle tone. And as dentists, we can use oral appliance, and physicians use CPAP, a mask with positive pressure giving to the lung. Surgery can be used, different kind of surgery, surgery to advance the tongue, surgery to open airway. There's a series of surgery. There is now new surgery where they implant electrode in close to the lung with a stimulator to the tongue muscle to open the airway. But this is for adults when nothing else works.
Mm-hmm. So what is the efficacy of this method? I mean, should we have some kind of privilege that this problem with the, which is the most important for us, sleep bruxism, is can be fixed, or we just only manage this?
Okay, we rarely treat bruxism. When bruxism is there, it will always be there. We can manage the consequence. The consequence for dentists is tooth wear, and for patient, then we use splint. If your patient is presenting any risk of breathing problem like snoring with cessation of breathing, which is associated with sleep apnea, with headaches, then we suggest to use lower splint, not our upper splint, because these can aggravate the sleep breathing problem. And you can start to think using oral appliance to open airway, but in the beginning, just maintain the airway functional. But before all these things, sleep position is critical.
Okay, so citing your words, the problem is not coming alone, just coming together. So what do you think is the relationship and how we can manage the patient with the sleep problems and pain problems?
Again, it's comorbidity, like we discussed bruxism, we discuss apnea. Sometimes they can be together, sometimes they are independent, not in every patient. Pain is also there. Headache is a marker of sleep apnea. Morning headache is a marker of sleep apnea. When you treat a patient with sleep apnea well with a CPAP and oral appliance, when headache go down, you know you do the good thing.
So what is your take-home message number 1 or 2 for the Polish dentists for the next maybe 1-2 years? We hope that will be very exciting, and we'll have luck that you'll come back to Poland next 2 years.
First thing is think to work in collaboration with physician, physical therapists, because cause of bruxism are not single cause. There is comorbidity. You need to know what's going on. Second thing, do screening of sleep disorder to better manage. Treatment is what we expect, but difficult to treat bruxism or treat pain. We can reduce consequence, improve quality of life.
Mm-hmm. Maybe just at the end, if we would like to be safe with our patients, means that we can make very valuable dental works, means, for example, full reconstruction for implants, and how we can manage the situation, just not to be sued by the patients that something was wrong.
So first, one patient is telling you they sleep everywhere, they have headaches, you should fill questionnaire about sleepiness, the airport, questionnaire about headaches, the MIDAS. There is stop buying another questionnaire for risk of sleep apnea and question about bruxism. So if they fill questionnaire, you have something in your file. You can record them for screening with some specific device for breathing and muscle activity. But again, as dentists, we use those tools for screening. And before crown and bridge, before orthodontic, and after, but we need help of physician if there is something abnormal. So dentists have to learn how to recognize what is abnormal. It's like cone beam CT.
Okay.
In cone beam CT, dentists can take cone beam CT, but they have to learn how to distinguish what is normal and abnormal.
Mm-hmm. And what is the role of the oral appliance when you make some kind of dental work? Do you recommend to use as a safety guard for the patient?
To use oral appliance?
Yes.
Yes.
After the ending the extensive dental work.
After extensive dental work, if no snoring, no risk of sleep breathing disorder, I suggest to use a bite splint, Michigan splint, whatever the name, but not thick, thin. If there is any risk of snoring, go on the lower jaw. If the risk is higher, use a mandibular advancement device, but non-titrated, in neutral position. And if there is problem, open airway with titration. But before that, don't forget sleep position. Many problems can be reduced by having the patient sleeping on the side, not in supine position.
Okay, so thank you very much. It was really practical, and we're really happy that we have the possibility to.
Thank you.
Thank you very much.